Pediatric urology. Vesicoureteral reflux is the retrograde projection of urine from the bladder to the ureters and kidneys. It may be primary reflux, which results from abnormal or insufficient insertion of the ureter into the bladder, or secondary reflux, which occurs due to congenital bladder outlet obstruction, such as posterior urethral valves or from neurogenic bladder. It is classified as follows. Mild reflux, grades I to 2, involves reflux into one or both ureters or kidneys, but with no ureteral or renal pelvic dilation, and it often resolves spontaneously. Moderate to severe reflux, grades 3 to V, involves ureteral dilation, renal pelvis, and calyceal dilation with associated calyceal blunting and possible nephropathy with impaired renal function in severe cases. In terms of clinical presentation, vesicoureteral reflux may present in infancy or childhood with febrile urinary tract infections, with particular concern for VUR if the UTIs are recurrent. Prenatal ultrasonography may identify hydronephrosis. Diagnosis is confirmed with a voiding cystourethrogram, which is the diagnostic test of choice used to detect abnormalities at the ureteral insertion sites and to classify the grade of reflux. For treatment, the physician should have a low threshold to treat urinary tract infections with prompt initiation of antibiotics. Surgery, specifically ureteral reimplantation, is generally reserved for children with symptomatic high-grade reflux. Grades 3 to V. In children with recurrent febrile UTIs and vesicoureteral reflux, daily antibiotic prophylaxis has been shown to reduce the number of febrile infections but does not prevent renal scarring. This benefit has not been demonstrated for children with recurrent febrile UTIs who do not have vesicoureteral reflux. Key fact: children aged 2 to 24 months who present with a febrile urinary tract infection should first undergo an ultrasound examination to evaluate the anatomy of the urinary tract. Avoiding cystourethrogram is indicated for recurrent febrile urinary tract infections and for abnormalities found on ultrasound. For children under 2 months of age, imaging is also recommended, although the evidence supporting this is limited. Cryptorchidism is the failure of one or both testes to fully descend into the scrotum. Prematurity is a significant risk factor. Other risk factors for cryptorchidism include congenital urinary tract abnormalities and certain syndromes, such as Prader-Willi and Noonan syndromes. If left untreated, cryptorchidism is associated with oligospermia, infertility, and an increased risk of malignancy. Diagnosis is made when the testes cannot be manipulated into the scrotal sac with gentle pressure, unlike retractile testes, and can be palpated anywhere along the inguinal canal. Treatment involves orchiopexy for prepubertal boys, while orchiectomy or close observation may be considered if the condition is discovered after puberty to minimize the risk of testicular cancer. If the condition is discovered in a newborn, surgery should be performed as soon as possible after 4 months of age, imperatively before 2 years of age, and ideally before 1 year. Earlier treatment has been shown to improve fertility and decrease the risk of testicular cancer and testicular torsion. In cryptorchidism, bringing the testes into the scrotum may lower, but not eliminate, the risk for testicular cancer. Inguinal hernia is most commonly indirect in children. The condition has a prevalence of 1 to 5% in newborns and is almost double in premature newborns. The prevalence is 3 to 4 times higher in male newborns. A hernia is defined as the intermittent protrusion of abdominal contents through an abdominal wall opening, which should be either direct or indirect. A direct inguinal hernia passes medial to the epigastric vessels behind the superficial inguinal ring and rarely enters the scrotum. An indirect inguinal hernia passes through the inguinal canal, lateral to the epigastric vessels. Incarceration refers to the entrapment of a hernia that is not reducible, while strangulation refers to ischemia and possible necrosis of the herniated contents, which can result in intestinal perforation. Treatment involves reduction of the hernia and timely referral to a surgeon. The risk of incarceration and strangulation is high, especially in infants under 1 year of age. Hypospadias and epispadias, both conditions, are congenital malformations of the male urethra that result in an abnormal opening. In hypospadias, the opening of the urethra is located on the ventral side of the penis, whereas in epispadias, the opening is found on the dorsal side. The underlying causes differ slightly between the two. Hypospadias results from abnormal fusion of the urethral folds during development, while epispadias occurs due to abnormal growth of the genital tubercle in the cranial instead of the caudal direction. Risk factors for these conditions include low androgen levels, advanced maternal age, a positive family history, and maternal exposure to environmental toxins that disrupt hormonal balance during pregnancy. Management typically involves surgical correction, ideally performed within the first 2 years of life. Circumcision should be avoided at birth because the foreskin may be required for reconstructive surgery. Key fact: circumcision refers to the removal of the foreskin of the penis. When performed during the newborn period, it generally has fewer complications and a shorter recovery time compared to circumcision done later in life. Circumcision may offer benefits, such as a reduced risk of urinary tract infections, certain sexually transmitted infections, and penile cancer. However, potential complications, though rare, include bleeding, infection, ulceration, cosmetic concerns, and urethral stenosis. Key fact: enuresis refers to the involuntary passing of urine. It can be primary, often due to immaturity of the reflex that awakens a child when the bladder is full, or secondary, which may be caused by an underlying issue such as a urinary tract infection or an anatomical abnormality of the urinary tract. Treatment is not always necessary, but for primary enuresis, enuresis alarms are generally considered the first-line management option.